Hello everybody, this is Dr. Nadeem and we are with NEURO-PATH Lectures, the Pursue series. All our lectures are available on YouTube. We have a Telegram group which you can join to access all lecture related information. A Google Drive where all the PDFs are available. These are the disclaimers. We are with Phase 3, which is recorded pathology lectures. And today we have Pursue 7Q, which is neuropathology. And we are streaming from IPGMER Kolkata. And to speak on today's topic, which is perinatal disorders, we have Dr. Shristi Butta, who is an MBBS Honors Gold Medalist, MD Pathology. She is a demonstrator in the Oncopathology unit of the Department of Pathology at IPGMER SSKM Hospital. She's got 12 publications in national and international journals. Her special interest is neuropathology, molecular genetics, and hematopathology. So I would request Dr. Butta to start her lecture on perinatal disorders. Over to you, madam.
Very good morning. We are back with our neuropathology lecture series, and this is Neuropathology Module 3, Brain Autopsy in Perinatal Asphyxia. So what do we plan to discuss today? We plan to discuss about perinatal asphyxia and its etiology, pathogenesis, and typical autopsy findings, focusing on hydrancephaly, porencephaly, schizencephaly, periventricular leukomalacias, and germinal matrix hemorrhage. We also would be discussing about bilirubin encephalopathy. So let's start. What is perinatal asphyxia? Perinatal asphyxia is the lack of oxygen, that is the lack of blood flow or gas exchange to or from the fetus in the period immediately before, during, or after the birth process. When placental or prenatal or pulmonary, that is immediate postnatal gas exchange is compromised or ceased altogether, there is a partial hypoxia or a complete anoxia that develops. This results in progressive hypoxemia and subsequent hypercapnia. What is the etiology behind this? Let's discuss. Majority of the cases of perinatal asphyxia occur intrapartum, although 20% occur in the antepartum and other cases do occur in the early postnatal period. However, majority of the cases are intrapartum. They involve causes that include maternal events, including hemorrhage, amniotic fluid embolism, and hemodynamic collapse, placental events like the acute abruption of the placenta, uterine events like the rupture of the uterus, cord events including the tight nuchal cord prolapse or avulsion, or for that matter there may be some intrapartum infections involving the mother in labor. What is the pathogenesis behind this perinatal asphyxia? It is similar to that we discussed in hypoxia and ischemia in adults. That is, there is energy failure, that is failure of the sodium and potassium pump resulting in depolarization, glutamate discharge in the synaptic cleft, opening up of the NMDA or AMPA receptors, a calcium influx that results in activation of the catabolic enzymes and activation of nitric oxide synthase and nitric oxide production, subsequently resulting in cellular injury or necrosis for that matter. However, it must be noted that the antioxidant defense mechanisms are not fully developed in a newborn. The patterns of the glutaminergic neurotransmission are evolving and the glutamate receptors are more abundant in the deep nuclei. Note that the glutamate receptors are more abundant in the deep nuclei than in the cortex. So, unlike adults, the basal ganglia, thalamus, and brainstem of the mature infants are affected more severely than the cerebral cortex and hippocampus, probably because they have a higher energy demand and have more developed neurotransmission compared to the brain cortex. A similar predilection of the basal ganglia and brainstem has also been reported in the Leigh syndrome, which is nothing but a mitochondrial encephalopathy affecting the young adults. Now, what are the patterns of the brain damage? That is, what are the autopsy findings? One of the main autopsy findings is a hydrancephaly. What is this? As the term implies, there are several conditions that result in extensive replacement of the brain parenchyma or the brain tissue by CSF. And the major cause might be a developmental error or an intrauterine disorder that destroys the brain parenchyma, particularly due to hypoxia or ischemia. Excessive pressure due to the CSF in the lateral ventricles destroys the midline structures as well, and that results in a thin cerebral mantle. Let's see. So let me just highlight this with a laser pointer for you. Just a second. Yeah. So here it is. This is your brain parenchyma, which has been completely destroyed and replaced by the cerebrospinal fluid, as you can see. Okay. And there is a thin cerebral mantle that you can very well appreciate. So this condition is referred to as hydrancephaly and is one of the major autopsy findings in patients with perinatal asphyxia. Let's move on. What is cystic Nkefalo Malaysia? As the term implies, there is formation of cyst and there is destruction of the brain parenchyma, that is Nkefalo Malaysia. This is a multicystic disorder, okay, which is characterized by presence of variable sized cysts in the brain in the developing fetus or infants, particularly in the periventricular location. Look at the diagram. Okay, these are the ventricles, and in the periventricular location, as you can appreciate, you have these cysts here. Okay, the cysts start in the periventricular location and may extend up to the cortex. The cause of the formation of these cystic lesions is secondary to any ischemia or hypoxic insult, which leads to the subsequent liquefactive necrosis and formation of a gliotic cyst wall. So what do we see here? We see that there is complete destruction of the brain parenchyma or Nkefalo Malaysia that has been shown here, okay, with the formation of variable sized cysts, okay, as you can see in the microscopic picture shown alongside, that there is complete destruction of the brain parenchyma by numerous large and small cysts here and there, okay, and there is gliosis that you can make out in the surrounding brain parenchyma. Okay, let's show more pictures. So here you go. You have a cyst wall, right? Here, this is the cyst wall. This is the gliotic cyst wall that you can see. You have lots of astrocytes, few gemistocytes as well. The astrocytes have been highlighted by the GFAP immunohistochemistry, that is the glial fibrillary acidic protein. And in addition, what are these? These are nothing but the microglia, and they've been highlighted by CD68 immunohistochemistry. Let's move on. What is Yuli Gyria? Now, Yuli Gyria is another important condition. Okay, it refers to the shrunken and flattened cortex, usually due to the global hypoxic ischemic injury in infants. It is a cortical scarring. Note, it is a cortical scarring in the deeper regions of the sulcus. So if this is the gyrus, then this is the sulca, as we all know, right? So there is cortical scarring in the deeper regions of the sulcus that leads to destruction or distortion of the gyri, resulting in the characteristic mushroom-shaped gyri. Okay, so let's see. So this is the characteristic mushroom-shaped gyri that you can make out here. Okay, and there is cortical scarring, particularly involving the sulcus, resulting in a mushroom-shaped gyri. However, it must be noted that for patients who survive this Yuli Gyria can be an important cause of epilepsy or seizures in infants. What about the hippocampus? Now, hippocampus is less frequently affected in infants than in the adults, as we had already discussed in the previous class. In few cases, however, combined damage of the hippocampus and pons result in what is called as pontosubacular necrosis. Now, what is this? Let's see. Now, pontosubacular necrosis is characterized by these pontine neurons which show characteristic karyorrhexis, that is fragmentation of the nucleus, cell shrinkage, and characteristic eosinophilic cytoplasm, particularly resulting from hypoxia, right? So hypoxias result in anoxic neurons, which have a characteristic eosinophilic cytoplasm. In addition, in pontosubacular necrosis, there is also karyorrhexis, which can be appreciated in these neurons. Let's move on. So now coming to porencephaly. Now porencephaly is a rare congenital disorder that results in a cystic degeneration and Nkefalo Malaysia with the formation of the characteristic porencephalic cysts. Okay, so now what is this Nkefalo Malaysia? Nkefalo Malaysia is nothing but the softening or loss of the brain parenchyma after any sort of cerebral infarction, ischemia, infection, or for that matter trauma or any other injury. These focal cystic porencephalic cysts of Nkefalo Malaysia often communicate the ventricular system with the subarachnoid space. It is usually a result of an intrauterine ischemic event early in the gestation. So these are the porencephalic cysts which allow a communication of the ventricular system with the characteristic subarachnoid space. Now, this condition of porencephaly has often been associated with a mutation, and as we had discussed in the previous class, the mutation involves the COL4A1 gene. Now, this gene encodes the collagen 4A1, a component of the vascular basement membrane, and causes porencephaly and cerebral hemorrhage, particularly in infants, whereas it causes lacunar infarct, cerebral hemorrhage, and leukoencephalopathy, particularly in adults. Right? Let's move on. Now, what is schizencephaly? Now, schizencephaly, as the term implies, it's a congenital cleft in the cerebral mantle. So look at this. Okay, there is a congenital cleft that has developed, and this cleft particularly extends from the pia to the ventricles, right? So this darkened area shows you a cleft that has resulted, and there is a missing brain parenchyma that you can make out here. This cleft usually results from a genetic mutation or a physical insult such as infection, infarction, hemorrhage, or stroke while in utero, or any exposure to a toxin. Even infections with cytomegalovirus in pregnancy can result in schizencephaly. Now, schizencephaly is a condition which is characterized by, yes, clefting, and this cleft communicates the pia with the ventricles. And there is loss of the intervening brain parenchyma here. Now, porencephaly and schizencephaly are thought to be due to fetal intracranial hemorrhages. They are nothing but the two sides of the same coin. However, it must be noted that porencephaly usually results from a mutation involving the COL4A1 gene. It must also be noted that schizencephaly is a type of a cortical dysplasia. Remember the focal cortical dysplasias that we discussed in the previous class, which is characterized by the formation of clefts in the cerebral mantle. It is also one of the causes of epilepsy. Now, what is periventricular leukomalacia? Periventricular leukomalacia is a cerebral lesion that typically develops in preterm neonates with prevalence rate of 2 to 25%. It characteristically involves the white matter and results from either a birth trauma or an asphyxia or cardiopulmonary defects, premature birth or low birth weight, immature cerebrovascular development, and lack of appropriate autoregulation of the cerebral blood flow in response to hypoxic ischemic events. Now, what are the grades? Now, before we go into the grades, let's see. This is the ventricle. Okay, and this is the subventricular region, as you can make out. This is the periventricular white matter, and usually periventricular leukomalacias involves this region. That is the periventricular white matter. This is the central white matter, and this is the subplate region, right? So that is very important. Now, different grades. It can actually be a focal cystic necrosis, that is a cystic periventricular leukomalacia, a focal microscopic necrosis, or for that matter, a non-necrotic diffuse white matter injury. Note that the most common pattern is a diffuse white matter injury. Now, coming to cystic periventricular leukomalacia. In cystic periventricular leukomalacia, as you can make out, there is a bilateral, roughly symmetric white matter loss. Okay, there is a white matter necrosis that you can make out. Note that there is no difference that you can make out between the cortex and the between the cortical gray matter and the white matter here. As you can see, there is a complete white matter necrosis which has involved the lateral ventricles, especially in the frontal and occipital lobes. The evolution of these lesions is similar to that of the infarcts. There is first of all a liquefactive necrosis, which is subsequently followed by neurophagocytosis, by microglia. There is also cavitation and subsequent formation of a gliotic scar. However, it must be noted that an added feature of periventricular leukemia and other necrotic brain lesions typically involves calcification, which makes lesions look whitish. Okay, so here it is. These are the whitish lesions that you can make out here. In addition, what is this? The microscopy shows large number of cysts. Okay, and these cysts are also characterized by characteristic gliosis in the surrounding brain parenchyma. There is also some degree of necrosis here, up here, okay, and these arrows are going to point towards your calcification. Okay, let's look at the high power view. These are the calcific foci that have been highlighted here. They appear basophilic and sometimes slender, rod-like. Now, what is focal microscopic necrosis? In focal microscopic necrosis, small necrotic lesions form microcysts or do not cavitate at all, but collapse into a gliotic scar. Okay, so there is necrosis, but however, the necrosis does not cavitate, or rather, if it does, it just forms simple microcysts and subsequently results in the formation of a glial scar. So as we can see here, this is the glial scar that has developed. Okay, the background is showing a lot of gliosis here. Let's look at this picture. There is necrosis here. The asterisk is showing you the necrosis here. Okay, and what are these? These that have been highlighted by GFAP? Yes, it is nothing but the astrocytes, right? Now coming to the diffuse white matter injury. Now diffuse white matter injury is characterized by hypomyelination, gliosis, decreased white matter mass, dilatation of the lateral ventricles and atrophy of the corpus callosum. It is characterized by what are these? Typical white matter gliosis. So GFAP is highlighting your typical white matter gliosis. Okay, so diffuse white matter injury is characterized by hypomyelination and a diffuse white matter gliosis. Now coming to another important entity, that is germinal matrix hemorrhage. Now germinal matrix hemorrhage is a frequent lesion in the premature babies who have characteristically hyaline membrane disease and respiratory distress syndrome. What is a germinal matrix? Let's see. Germinal matrix is a thick cellular layer of immature cells, okay, that is the neuronal and the glial precursors, just under the ependymal lining of the ventricles, right? This thick layer is traversed by the blood vessels, as you can see. These blood vessels have no structural support and lack autoregulations, which makes them more susceptible to fluctuations of the vascular flow. So, in babies with hyaline membrane disease, these vessels dilate because of the passive congestion and their walls are damaged because of hypoxia, and so subsequently these vessels rupture and result in what is characteristically called as germinal matrix hemorrhage. Now grading. As you can see, this is the normal coronal view of the brain. Okay, and what you can appreciate here, this is the ependyma lining the ventricles, and just in the subependymal region you have the germinal matrix layer. Okay, and this is the caudate nucleus, as you can appreciate. So what is grade 1 germinal matrix hemorrhage? Let's look at this diagram. The hemorrhage which is just confined to the germinal matrix is grade 1 germinal matrix hemorrhage. Grade 2 is the one which extends and involves less than 50% of the intraventricular space. That is, when the intraventricular involvement is less than 50% of its volume. Grade 3 is when there is an intraventricular extension involving more than 50% of its volume. That is typically grade 3. Whereas grade 4 is not only involvement of the ventricles but also extending into the surrounding brain parenchyma. That is an intraparenchymal extension, which is typically considered as grade 4. Now the hemorrhage usually starts in the thalamus and the caudate nucleus, okay, adjacent to the foramen of Monro, where the germinal matrix is thicker and is frequently bilateral. If it is large, it ruptures into the ventricles, remember the diagram, and flooding the ventricles, that is the lateral and the third and the fourth ventricles, it results in characteristic intraventricular hemorrhage. This intraventricular hemorrhage might be less than 50% or more than 50%. Thick clots subsequently develop in the ventricles, and that can cause a blockage of the foramen of Luschka. Large bilateral intraventricular hemorrhage causes acute distension of the ventricles, and that causes a blockage of the subarachnoid space, resulting in what is characteristically called as hydrocephalus. This is due to the clots or the gliosis of the aqueduct and obliteration of the foramen of Luschka and the subarachnoid space, right? So here we go. Here what do you see? You see a germinal matrix hemorrhage, okay? And this is the whole mount. And here we have a characteristic low power view. And what do we see here? We see a lot of hemorrhage here, okay? And the hemorrhage has typically resulted in the germinal matrix layer, okay? Here, that is just beneath the ependyma. So let's move on. So now coming to bilirubin encephalopathy. Bilirubin encephalopathy is also called as kernicterus. It is an acquired metabolic encephalopathy of the neonatal period. Kernicterus is caused by unconjugated bilirubinemia, note unconjugated hyperbilirubinemia, that develops due to, particularly from Rh incompatibility. It might also result from hereditary spherocytosis or other hemolytic disorders for that matter. There may be a chance of developing kernicterus even from disorders, typically the congenital hyperbilirubinemias, where there is inability of the liver to conjugate bilirubin. However, it must be noted that this bilirubin binds to the cell membranes and is toxic to the neurons and oligodendroglia. It often damages the mitochondria and inhibits oxidative phosphorylation and causes calcium release as well. And that promotes apoptosis. It also stunts the axons and dendritic growth. Right? What is the mechanism of conjugation? As we already know that senescent RBCs, okay, and some degree of ineffective erythropoiesis for that matter, results in formation of heme. This heme in the presence of heme oxygenase is converted into biliverdin, which in the presence of biliverdin reductase is converted into unconjugated bilirubin. This unconjugated bilirubin forms a complex with the albumin and enters into the liver, and in the presence of UDP glucuronil transferase, it's converted into the conjugated bilirubin. This conjugated bilirubin enters the intestinal flora and is converted either to urobilinogen or stercobilin. 20% of it is converted into urobilinogen, of which 5% moves to the kidney and is excreted via the urine. 95% enters the liver and goes back for the enterohepatic circulation. Stercobilin forms 80% of the conjugated bilirubin, which is excreted in the feces. Now, what are these congenital hyperbilirubinemias which might develop kernicterus? One of the major causes of kernicterus can be Crigler-Najjar syndrome. Now, this is an autosomal recessive disorder. It is either type 1 or type 2. Type 1 is characterized by a complete absence of the UDP glucuronil transferase, whereas type 2 is characterized by a partial absence. There is defective UDP glucuronil transferase, which results in characteristic unconjugated hyperbilirubinemias. It must be noted that kernicterus is very likely in type 1 as compared to the type 2 Crigler-Najjar syndrome. Gilbert syndrome, on the other hand, is also an autosomal recessive disorder where there is mutation in UG1A1 gene encoding the UDP glucuronil transferase. It may be noted that there is a reduced activity of the UDP glucuronidal transferase, and that results in characteristic unconjugated hyperbilirubinemias. However, the jaundice that develops is mild and usually does not require much of a treatment. Let's move on. We have Dubin-Johnson syndrome as well, which is an autosomal recessive disorder which is characterized by liver hyperpigmentation. There is abnormal transfer of this conjugated bilirubin into the biliary system due to mutation of the ATP binding cassette subfamily C, that is ABCC2G, which results in characteristic conjugated hyperbilirubinemias and resulting moderate jaundice. There is another syndrome which is called as Rotor syndrome, which is also an autosomal recessive disorder which is characterized by an abnormal excretion of bilirubin resulting in, yes, conjugated hyperbilirubinemia and a moderate jaundice. Of all these cases, it must be noted that Kriegler-Natcher syndrome type 1 is characterized by Kernicterus. Unconjugated, unbound circulating bilirubin often crosses the blood-brain barrier. Remember the blood-brain barrier that we had discussed? Because this unconjugated bilirubin is lipid soluble and it penetrates the neuronal and glial membranes as well. Hypoalbuminemia, low pH, which weakens the albumin-bilirubin bond, and drugs like salicylates or sulfonamides for that matter that compete with bilirubin for albumin binding increase the amount of unconjugated unbound bilirubin. Prematurity and low birth weight are greatest risk factors for bilirubin-induced brain damage. So now, what is this? Let me just show you with a laser pointer. Yes, so this is the caudate nucleus, this is the putamen, this is the thalamus, hippocampus, and what is this? This is the globus pallidus. Bilirubin has a special affinity for globus pallidus, hippocampus, and the subthalamic neurons. In the hippocampus, the Kernicterus involves the CA2 and the CA3 sectors more than the CA1 or the CA4 sector. It must be noted that in hypoxic ischemic encephalopathy, it was the CA1 sector which was more commonly affected. The reason for this topography of the lesion is, however, not understood. In severe Kernicterus, affected structures have a characteristic bright yellow color. And as the term implies, Kernicterus means yellow or nuclear jaundice. So what do you see here? You see the characteristic yellowish discoloration of the subthalamic nucleus and the hippocampus here. Okay, and here what do you see? You see the characteristic yellowish discoloration of the cerebellar tonsils, right? What about the microscopy? We see the characteristic anoxic neurons, okay, that is the Purkinje cells have developed necrosis in the cerebellum as shown by this arrow, and the arrowheads are pointing towards the yellowish pigmentation that is present in the characteristic granular cell layer of the cerebellum. Okay. In addition, in the cerebrum, what is also seen is the gliosis, the neuronal loss, and the characteristic anoxia. Okay, the anoxic neurons, note, have a characteristic eosinophilic cytoplasm and a hyperchromatic or condensed nucleus. So, what do we see here? We see the characteristic Alzheimer's type 2 astrocytes. Yeah, they have an enlarged nucleus and a margination of the nuclear chromatin, which characteristically causes clearing of the nucleus. These astrocytes are metabolically hyperactive, and they are not only seen in bilirubin encephalopathy but also seen in hypoxic ischemic encephalopathy, as we had discussed previously, and also in hepatic encephalopathies. Now, it must be noted that Kernicterus, as a result of Rh incompatibility, is very rare. The reason can be ascribed to the fact that there is Rh isoimmunization which has prevented this phenomenon. In a Rh negative mother, if Rh immunization with anti-RHD immunoglobulin is given within 72 hours of birth of an Rh positive baby, or in any situation in which there is feto-maternal hemorrhage that has occurred, then in that case this particular Kernicterus can be prevented. In addition, a systematic use of phototherapy in the NICU units reduces bilirubin by breaking it down to the water-soluble derivatives. So eventually, let's summarize our autopsy findings in a case of perinatal asphyxia. Now, perinatal asphyxia can result in a damage to the basal ganglia, thalamus, and brain stem more than the cortex. The autopsy findings typically include a hydrancephaly where the brain parenchyma is lost and the brain is converted into a cystic structure filled with CSF, and there is a characteristic thinning of the cerebral mantles. In cystic Nkefalo Malaysia, the cysts characteristically involve the central white matter, unlike a periventricular leukomalacia where there is involvement of the periventricular white matter. Yuli Gyria is a condition which is characterized by characteristic flattening of the cortex, a scarring of the sulci, and mushroom-shaped gyri. Hippocampus and pons are less frequently affected in infants than in adults, and when affected show a characteristic pontosubacular necrosis with characteristic neuronal karyorectic bodies. Porencephaly and schizencephaly are the two sides of the same coin. There is characteristic communication of the ventricles with the subarachnoid space. Periventricular leukomalacia characteristically involves the periventricular white matter and shows either a focal or a diffuse lesion. Germinal matrix hemorrhage is a frequent lesion in babies which usually present with hyaline membrane disease. In bilirubin encephalopathy, unbound, unconjugated circulating bilirubin often crosses the blood-brain barrier, and because of its lipid-soluble nature, it penetrates neuronal and glial membranes. When taking into account the microscopic features, then they are dependent on the perinatal anomaly. Briefly, all the cases, however, show features of hypoxia with anoxic neurons, gliosis with or without formation of a gliotic scar, and a cystic degeneration. Bilirubin encephalopathy is characteristically associated with cytoplasmic yellow pigmentation and often an astrocytic swelling, usually the Alzheimer's type 2 astrocytes. Periventricular leukomalacia is often characterized by white matter gliosis and calcification, which are its typical features. So eventually, I'd like to end my talk for today with a quote by Emily Dickinson, which says that the brain is wider than the sky. Much, much wider. Right. Okay then. Thank you so much for your patient hearing.